it over to you, Christina. Thank you.
Thank you, Tom. So grateful for everybody here who's done work on policy in the last 3 years for the Knowledge Network. We've had a wonderful policy work group that's done just fantastic work. We've helped get bills introduced. We're helping making some little small changes at SAMHSA with openness to different things. We did not do work group alone work this summer since the last summit, but we're going to get back together and get that started again this fall. But each of us individually was still doing work. April asked me actually to talk about the mental health in the U.S. as a whole today. And I want to start with some really ancient history here. You see this is a fossil, and I want to go to the year 2009. So there was a question that I got to email all of you who were here before the first summit, and I asked, what is the biggest task ahead of us in transforming mental health care? And I got some of your responses via email, some of you I interviewed on the phone, and it was wonderful this last couple weeks to read through all of those initial responses. And I called a couple out here. Todd Citron, I know who's here, you said we need to facilitate cost containment. Irv Brinker said we need to see, we need behavioral health care, even as an industry, to see that we need healthcare services. In 2009, we just had finished a study with CRI and SAS showing that around 11% of behavioral health providers even had health IT, 11%. I'm happy to say today the awareness is quite a lot higher, and we're at 30%. Still not fantastic, but quite a lot better than back in 2009. And I know many of you in this room have helped write those articles for the Behavioral Healthcare News, helped me give those speeches at Open Minds and other settings at National Council to really raise the awareness for the need for health IT. Develop organizations that emphasize quality and accountability. It was from Dr. Hennessy at SAMHSA, from Dr. Rick Shelton, who we've been talking about this morning. Ensure there's health IT that's set up to support relational information transfers. Create learning organizations from Linda Rosenberg. Develop new business models from Don Heavey. And we are getting closer. We still have a lot of work to do. And when you look at all of these, a lot of these are linked to policy. So for getting integrated care, there wasn't the PBHCI granting funding stream back in 2009. Thanks to the leadership of National Council and many of you in the room, SAMHSA decided to fund that, to see, can mental health do what Dr. Dross at Emory has shown could be really helpful? Can mental health providers do that? As we've heard from Rand, there's some mixed results there. My own perspective from looking at the research as the quality monitor for CIHS is that's because there's been some providers who've not taken it very seriously. And over a 3-year time span, if you're on an atypical antipsychotic, you gain weight. And there's been some providers who've taken it seriously and they've helped people lose weight. And then it washes out in the middle. So that's my little theory about what's going on there. I see a nod from our RAND researcher in the back of the room. But one of the things I have to say with that is I would love, if we could, look at that data further. Which of those organizations had that real-time health IT supporting that relational information? Were they showing graphs to patients of your weight over time, going up or going down? Were they not just saying, are you smoking or not? Or are they showing them the CO2 monitor that they were supposed to be tracking, but a lot of the people didn't actually track the CO2 levels. They didn't go and buy the CO2 monitor, which is kind of an issue if you're getting a multi-million-dollar grant and you're not affording to buy a CO2 monitor and then train your staff to use it. So, but as you can see, any of these things, they're all linked to policies. They're linked to policies in our organizations. They're linked to policies in our states. They're linked to policies federally. And there are some things that we need to do ourselves that we can't wait for the federal government to do. One of the things that our group worked on the last couple years is trying to advocate for a minimum data set for behavioral health. And had a series of good conversations with different staffers over the years. And one of them said, you know what, the federal government, it's going to take us about 5 to 10 years to figure this out. And by that point, I'm not even sure if there's going to be a community mental health system there or whether you guys will be put into regular health. If you guys want to do this and you want to prove value, you really need to act fast because I'm not sure the federal government can get things together. She said that to me a year ago, And sitting here today, I have to say, we're not sure the federal government can even get the budget together. So if we really, as a community, want to be serious about having a minimum data set for outcomes, for behavioral health, in our line analytics, we need to work together, to have unity, to have policies internally to start making that happen ourselves. So what are our biggest tasks today here in 2013? I still have hope for the behavioral health IT bill. Our Hill Day was enormously successful this year with National Council and NAMI and other partners. And after our Hill Day ended, I got such response from the staffers that I met with, and I know other people got responses too. We had a pretty good senior member of the House say, I'm gonna start writing landmark health IT legislation myself. And he was working with some of the representatives, staff that I'm used to working with. Sadly, that's not going to get introduced right now until the government doesn't shut down. But there is hope, and one of the things he included was behavioral health IT in his bill. And there's a behavioral health IT bill in the House and the Senate. We've helped to get that going now, I guess, 3 or 4 different versions. After our first meeting together in 2009, we created the National Behavioral Health IT Coalition. Which now has membership beyond just behavioral health. We have national psychiatric hospitals, we got the National Jewish Federation, and the National Health IT Coalition with a lot of big industry is also part of it. And even hospitals are now getting in the game because they realize, gosh, we're not able to cut all these costs, and wow, look at the top 5% in costs in care and Medicaid. 86% of them have behavioral health disorders. The ACOs are trying to start, reducing costs, but they're not being able to get behavioral health data from Medicare and Medicaid because of different restrictions going on. And so they don't even know who to partner with. So there's a lot of issues going on with behavioral health being bifurcated from the national health IT system. And I think we've done a really good job of explaining to people, this is a problem. I've yet to talk to anybody who says it's not a problem in Key. If we can't track things electronically, we can't track outcomes, we can't do the communication, we can't be held accountable, we can't have rapid audits. But we need to bring this to the finish line, and we need all your help and support to get that finished. It's not enough that just 30% of the behavioral health system has health IT. That is not a behavioral health system. We need to at least get over to the 50, 60% mark to be viable as a system. That's my personal opinion. I also believe we need a federal definition for behavioral health providers. There have been some massive regulatory changes in the last couple of years. Many of you are aware of the lack of funding, basically, for partial hospitalization programs now, which is a key step between just outpatient clinical care and then inpatient care. But because there wasn't a federal definition, the only way that CMS could regulate these fly-by-night CMHCs who were basically trying to bankrupt CMS through millions and millions of fraud was to make it unfinancially viable for any community mental health center to provide that service whatsoever. So we can only be regulated with basically a hatchet unless there's a federal definition. And if you go across the country, just like we've seen in Enlighten, even within our own organizations, you don't know what services you're going to get. One provider helps kids, one provider doesn't. 60% of rural counties do not have a provider nearby that provides services to kids. And that's unacceptable for trying to reduce mental health issues later in life. And then a gold standard, and that's in the Excellence in Mental Health Act. And then our third thing I think we need to bring to the finish line is a gold standard performance measures for behavioral health. There is a whole lot of work being done in the federal government. Samson's been working on this for a while. They have their national behavioral health quality measures. They had them out for comment back a couple weeks ago in September, and those will keep going forward. Now, I would like to see us adopt some of those earlier and see, can we prove efficacy with them before those are partnered with HEDIS measures or other things in order to measure care, so we can prove our value. So why are these tasks important? Many of you have seen this equation before, but I think behavioral health, just like the rest of healthcare, we need to look at what are our outcomes over our costs and use that to promote value. One of the things is we need to start, as I said before, start all tracking the same kind of outcomes so we can track apples to apples instead of apples to oranges. Another thing is we need to work with our managed care companies, payers, states to be able to get that cost information. And we're working on a couple pilots related to that, and I hope we will be successful. We all need to answer these questions. What are the components of value? What is the cost of achieving change? What is the value of a service? Is my organization ready to be held accountable for creating or losing value? You know, what's the difference between 12 services or 9 services for somebody, and what kind of service does it matter? Another thing that, as some of you saw yesterday, there was a wonderful map that Dr. Dress showed of medical homes throughout the U.S., and that was a health affairs map, and it was from 2012. And it showed almost about 23 states filled in with a quarter more on the way. My belief, because of the compensation states are going to get for medical homes, is that in the next 3 to 4 years, probably everybody in this room is going to have some kind of a medical home as part of the care they're expected to provide. CMS came out with regulations this winter regarding how can you judge your medical home if you're a payer or MCO. And these are the conditions that you are supposed to judge. BMI, engagement for addictions, depression screen follow-up, high blood pressure, sensitive condition admission to ambulatory care. So if you have, and one of the sensitive conditions is schizophrenia, is depression. Are they getting services in the community? Care transition from hospitals, are you getting seen quick enough? Follow-up after hospitalization for mental illness, and then all-cause readmission. And we have 3 of these in Enlighten right now, and we're working steadily to bring more of them up. Some of them are data that we don't track ourselves. We have to get that from our managed care and other payers, which is a complicated process. The Excellence in Mental Health Act would require us to, if we want the special considerations and rate reimbursements from states, to become certified behavioral health centers. You have to use evidence-based practices if you want to be a certified behavioral health center. You have to do person-centered planning, including crisis. And then you have to monitor key conditions. And you can see here in that list, this is a lot of what we've been talking about today, talking about diabetes, hypertension, blood pressure, cardiovascular disease. Having a good standard knowledge of these diseases for all of our case managers, all of our therapists, being able to track that is really important. So if you've said no to any of these questions, if you're not totally ready, you're so not alone. And some of the reasons that we're not ready are things that we can control and we can change organizations. Some of them are things we can't control. You know, we may not be able to get reimbursements in our states or federally for doing some of this care. If your state hasn't opted into a health home, or you don't have a case rate and you're trying to do everything fee for service, it's extraordinarily expensive to track these conditions or pay attention to this. There's a perverse incentive not to do this work. And we have some data now, we have some information to help work with you, your payers, in order to switch that. And then also we're advocating on the federal level to make it more rewarding for states and for payers to help us be more flexible, to have more braided care for our patients to improve their outcomes. One of the things I firmly believe is we can all make a difference. And you see here 2 pictures of people in the room. One of them is Kathleen Varda. For her policy work, she's done a whole lot. But in 2011, one of the things she did was save millions in funding for women in addiction programs in Georgia. Another person in this room, Debbie Taylor-Tate, who's in the back room, who didn't know she was going to be on this slide. Sorry, Debbie. She helped. She's done amazing work from when she was working with Governor Alexander, and then also when she was FCC commissioner. But I know one of the things she worked behind the scenes that one of my friends who's an advocate told me about was she helped persuade Republican leadership to make sure that mental health coverage was included in SCHIP funding. And it's relationships and care and having the facts and being persistent. And just think of you and your picture right there. What do you want to be your goal for your agency, for your state, federally, and how can you get there? And I just wanted to share this advice that Debbie gave me several years ago. Sorry, Debbie. So build your relationship with your congressperson before you need them. Don't wait till you need a vote or money. Make sure they know you, your face, your organization. respond to questions and provide staff statistics when there isn't an issue that they know about. And one of the things, if you're a member of the Knowledge Network, you can ask CRI, hey, do you have something? We very well might have a white paper or a one-pager or something else to help you or can help you find it. Or we might be willing to develop it for you, especially if you can give us enough notice. Always offer to help your member of Congress to do what they're trying to accomplish, and try to figure out where you're aligned with that. Invite to every event, appreciate staff, use any press story to send a personal note, offer help if they suffer a tragedy or it's somebody in the district suffers tragedy, and let them know when you're offering help as well. Offer to be speechwriter, research staff on things that pertain to health or mental health. You know, it took a couple years of us offering for them to say yes. And it's been a pure pleasure being able to do that for different members of Congress and their staff. And when I first started offering, I never thought they would actually say yes. And now they are, and it's really shifting policy, which is very helpful. So just want to inspire you all to do that.